Good afternoon, everyone, and welcome to the 2021 Western Carolina University Graduate Research Symposium Physical Therapy section. My name is Dr. Tim Eckert, and I will be serving as the moderator of this session. Today, we have the privilege of hearing from 8 teams of student researchers from the Department of Physical Therapy. All researchers presenting today are second-year Doctor of Physical Therapy students who, over the last year, have worked in collaboration with faculty members to conduct an original research study, methodically review the state of scientific literature on a specific topic, or create a scholarly product to enhance community health and engagement. Each group will present a 12 to 15-minute oral presentation providing us with the context, scope, results, and implications of the scholarly work they have engaged in over the past year, followed by a 5-minute question and answer period. Audience members are welcomed and encouraged to ask questions of each team of researchers using the Zoom chat feature. For those not familiar with Zoom, the chat feature is located near the center of the menu bar at the bottom of the Zoom window. By clicking once on the chat icon that looks like a speech bubble, you can bring up a text box in which you can type a question and submit it by pressing the Enter or Return key on your keyboard. You will note that the chat feature defaults to sending your message to everyone. We would ask that you please leave this default in place so that all presenters, audience members, and moderators can view your question. You do not need to wait until the end of a presentation to submit your question, but our presenters will hold off on answering all questions until they have completed their presentation. I would also encourage you to turn your camera on to allow our researchers to see you while they are presenting the projects they've worked so hard to complete. Please note that any microphone you may be using was muted upon entering today's session. We would ask that you remain muted throughout the entire session. If you accidentally unmute yourself, one of our moderators will mute your microphone for you. We will begin with the first half of our session today, which features 4 presentations followed by a 15-minute intermission. If you would like a copy of the program for today's event, one is now available in the Zoom chat feature for download. And with that, we will introduce our first student group, the project entitled Creating an Online and Video Learning Adjunct for Didactic Education in Physical Therapy, presented by Cameron Green, Allison Plasted, Christy Rowe, Sebastian Fondez, and Shane Loaf, with faculty sponsors Drs. John Carzoli and David Hudson.
Based online learning tool specific to physical therapy education. Our group is comprised of second-year physical therapy students Sebastian Fondez, Cameron Green, Shane Loaf, Allison Plasted, and Christy Rowe, and is guided by faculty advisors Dr. John Carzoli and Dr. David Hudson. We've all been there. It's late, we're reading through our textbooks, wishing we could see what the authors are talking about, wishing that we could put our hands on the feet, the shoulders, the knees of imaginary patients, or fumble with a goniometer we've just learned to use. It's tough to learn physical therapy from a textbook, and tougher still to comb through a sea of videos on YouTube to determine which clinician has the right idea. Physical therapy students typically have a wealth of materials at their disposal that are poorly organized across subjects and lacking in centralization. Reviewing materials for gait deviations and movement dysfunctions can be challenging as we hop between videos that focus on tests and measures or use poor quality videos that attempt to duplicate the teaching process gained from physical therapy school. Units may be scattered throughout YouTube playlists or placed beyond a paywall so that we can only access a piece of the puzzle. Videos that aren't behind a paywall may be dated and of poor quality so that we can't clearly see what the clinician on screen is trying to accomplish. Our goal with this project is to bridge the gap between videos that only go over tests and measures and videos that more adequately flesh out how to perform an exam. We want to provide students with an easy-to-navigate resource for online learning that includes high-quality video demonstrating everything from what an exam by an experienced clinician should look like to how to perform specific tests and measures. From start to finish, our video learning platform will help students navigate the components of an exam with expert feedback and the ability to check their work. We want to bridge the gap between test and measure videos and quality examinations to provide a unique learning experience.
After identifying this gap in physical therapy learning materials, we reviewed research on education to come up with a format for our learning tool. The first piece of research mentioned here, called Decoding the Disciplines, helped us identify bottlenecks in physical therapy education. The bottleneck we chose to focus on is clinical reasoning. Clinical reasoning is the process a physical therapist uses to collect information from a patient, form and test hypotheses, and come to an optimal diagnosis and plan of care for the patient. The second piece of research is called the Systematic Clinical Reasoning in Physical Therapy, or SCRIPT tool for short. This education tool breaks down the physical therapy exam into different sections and takes pauses for prompted reflection and group discussion. This gives a learner a chance to test their understanding and improve their clinical reasoning skills during each section of the physical therapy exam using part practice. The third bullet contains other evidence-informed teaching and learning strategies we decided to utilize. These include individual learners working through problems first, engaging learners in rich team-based discussions, providing guidance afterwards based on expert clinician thinking, and finally, embedding questions and answers throughout learning materials. So based on this research, we put together a list of deliverable learning activities that we added to the learning platform. These activities include learning modules for each body region, and within each module, we added movement system examinations. These examinations include videos without narration, a pause for reflection and discussion, and videos with narration from the expert clinician within the video. This is a chance for the learner to understand the thought process during the exam. This is all followed up by an assessment of learning, and altogether, this is to help improve the learner's clinical reasoning and evaluation skills.
To bridge this gap previously mentioned, we decided to create a video-based online learning tool on the Canvas learning platform, which will be the primary learning platform for Western Carolina University later this year. Our vision is to aid PT students and clinicians in developing observational and clinical reasoning skills that are essential in conducting a movement system examination, constructing a treatment plan, and performing evidence-informed interventions within the ICF model of disability. Through Canvas, our doctoral group has devised a learning platform that segments the body into crucial regions for examination. Within each region, we have created case studies that encompass the examination and evaluation process the physical therapists undergo while assessing a patient. The learner must simply click on a body region to access modules specific to that region.
All of the cases that we develop will follow a similar format. First, we provide the patient's medical and subjective history so that students can get a sense of the patient prior to viewing the exam video. This provides students with an example of how to obtain information from a subjective history, which is crucial to helping clinicians develop the soft skills necessary to form a complete picture of the patient. Next is the video, which follows the physical exam of the patient with relevant movements and movement system exam items. We think it is crucial that the first video is not narrated so that students can assess alongside the expert clinician in real time and form their own opinions free from outside influence. Following the video, we provide space for analysis. Then the examination video is presented again with the inner mind of a clinician talking through their thoughts on the patient's presentation. We follow this up with guidance on proper documentation. To evaluate student comprehension, we provided a quiz at the end of each case so students may receive immediate feedback on their grasp of concepts presented within the case. This is an example of the start of a case which gives the learner a pertinent medical history and subjective report from the patient. This is one of the first steps in an actual physical therapy exam. As we add more videos of movement dysfunction, we will also gather the patient history when it is relevant to the video being displayed. However, since we also hope to expand our library with some uncommon movement patterns that might not cause tissue pathology or pain, we will create a history and subjective to help guide learners in their thinking. The patient you're going to see in the next slide is a 28-year-old physical therapy student with a chief complaint of persistent low back pain from an injury sustained from Olympic weightlifting. Sitting and standing for long periods of time makes the pain worse, while changing the way he picks things up off the ground and Epsom bath salts seem to help his pain. The problem has progressed to the point that he cannot sit and study for his many midterms.
Next, we will show the unnarrated video of the expert clinician performing the exam. While watching, try to practice your own internal monologue of what you are seeing. After watching the unnarrated video, learners will be able to pause and write down what they noticed from the exam. This will allow for reflection of the material before moving forward with the expert narration. After the learner is able to write their own thoughts about the exam, the same video will be revealed with an expert's narration of what they are seeing. The goal of this is to develop the inner monologue of the learner as they work with their patients. The final page in the case is an assessment of learning. This is in the format of a typical online quiz. This will give the learner an opportunity to take the knowledge they just gained from observing, listening, writing, and discussing, and then apply it to a case-based questions that would need to be addressed in an actual physical therapy exam.
Finally, there's a solution. The times of wishing there was a way to view actual patients and cases is gone. No longer do you have to imagine how a patient presents with a certain movement dysfunction or how to efficiently tailor your examination based on the patient presentation. How, you may ask? There will be multiple cases for each body region to ensure adequate repetition and exposure that is conducive for learning. The typical case format that we walk through during this presentation, the history, the video without narration that allows learners to pinpoint specific impairments individually, analysis or reflection of the previous video, video with narration to further understand the patient's movement dysfunction and the associated impairments from the perspective of an expert clinician, and quiz to assess your knowledge of the subject matter. This will help PT students and clinicians develop clinical reasoning and exam skills in all regions of the body. This will be a highly utilized tool by PT students and clinicians because this truly bridges the gap of a high-quality, free, video-based learning tool that combines test and measure videos and examinations to provide a unique learning experience.
Thank you all for coming.
All right, we'll give our presenters a round of applause. And for the uninitiated, this is Zoom applause. You're welcome to do this. Yes. Excellent. What questions do we have for our first group of presenters? Feel free to type them in the chat. So we have a question. When will this be widely available?
By the end of the semester, we hope to kind of pilot a couple modules and, hopefully down the road, maybe this coming fall semester, it'll be available to more students with hopefully more cases that are available. Moving forward, I believe this doctoral project will be adding to this library of content.
And as of right now, we're focusing mainly on the orthopedic population, but in the future, other populations will be considered as well.
Excellent. So that was in response to our second question there. What other questions do we have for our first group of student researchers? Who will have access to these modules?
Initially, the modules were, like Sebastian said, we were hoping to pilot them within the Western Carolina program, and then the eventual long-term goal is for them to be publicly accessible.
Thank you. We have another audience member who wants to know what the most challenging part of the project was for you.
Our biggest issue is just we haven't really been able to do a lot of video stuff. So just because of COVID and trying to get people safely into the lab to do videos, that's been pretty limiting in terms of how much we can generate per se. And then just trying to figure out Canvas itself. It's definitely a learning curve trying to figure out how to essentially code for that. But I think now that we're more familiar with how to do it, just based off of the HIP presentation we just showed you, we should be able to move forward a little bit more quickly than we have been.
Excellent, thank you. Any other questions for our first group? How are patients recruited to participate in this process?
So as of right now, we don't really have any criteria that we're looking for. We haven't really thought about it, to be honest. If Dr. Hudson or Dr. Carzoli have some ideas, I'd welcome them to chime in. But really, we're just looking for any, either movement dysfunction or somewhat abnormal. I hate to say abnormal, but just different movement patterns that physical therapy students might find interesting and might be worthy and make it a easily teachable moment. So.
Thank you. Would it be fair to say that if someone's interested in potentially being a part of this project, to email either Dr. Carzoli or Hudson? Potentially?
Yes, that would be fine. Yeah, we do have plans to recruit from things like Map Health and other people that we see around that would be suitable for bringing into the motion lab to be able to capture this. It'll probably take a couple hours in a session to be able to record it adequately and set everything up. So it's a little bit of time investment on the person's part to be able to do it. But we hope to identify people that will be really suitable. And to Dr. Hyatt's question, it will span all levels of diagnoses. So I will be helping to pull in some of our, hoping to pull in some of our more neuro-based faculty to help with those types of patients on these cases.
Thank you. Our next question from the audience is there any discussion of using a similar format to demonstrate exercises for a home program in addition to use for educational purposes?
So as of right now, we are planning to use this solely as an education tool for within the physical therapy healthcare community, but that is a great idea, Tim, and we will keep it in mind.
My apologies, my mute button got stuck there. Last question from the audience here. What do you think the limitations would be for this type of project? Maybe in terms of application might be what that audience member is thinking about.
So personally, one of the things that I think is going to be a limitation for us is the fact that this is going to be just an entirely standalone thing that students will go to. So if they have questions, I'm sure they can reach out to Dr. Carzoli and Dr. Hudson in the future, but there's not really like an immediate way to get questions answered. And on top of that, it really is up to the student learner to take the time to actually write down what they're seeing in that unnarrated video before moving forward. And really that's going to be the way to maximize maximize the benefit from our platform. And it's a very real possibility that students won't do that. So I'd say that's definitely going to be a limitation moving forward.
Excellent, thank you. All right, well, let's have another round of applause for our first group. And with that, we will move on to our second group, which is entitled The Interdisciplinary Instruction and Perceptions of Online Learning Among Doctor of Physical Therapy and Physical Therapist Assistant Students, presented by Benjamin Hauska, Danny Harris, Emily Schall, Tim Levine, Mary Kelsey Trumps, and Kelly Smoot, with faculty advisors Dr. Wark and Dr. Eckerd.
Okay, hello everyone. So as Dr. Eckerd said, our title is Interdisciplinary Instruction and Perceptions of Online Learning Among Doctor of Physical Therapy and Physical Therapist Assistant Students. For the duration, you may hear Doctor of Physical Therapy called DPT, and you may hear Physical Therapist Assistant called PTA. Our purpose of this was threefold. First, we wanted Doctor of Physical Therapy students to use instructional design techniques to deliver 3 two-hour workshops to physical therapist assistant students. This allowed the DPT students to refine their teaching skills and supplemented the curriculum of the PTA students. When we look back at earlier research in this area, intentional joint education sessions like the ones we did during the pre-licensure phase can enhance the PT-PTA relationship even later in their career. Our second purpose was to do this effectively. So particularly in the time of COVID, we had to understand teaching and learning principles and integrate them into our delivery methods and understand the implications of the virtual environment on that. Finally, we wanted to know if we could take this information from the educational realm and move it into the clinical realm. As physical therapists in the clinic, what we do, or what we will do, is essentially education. And we wanted to explore how to best educate our patients virtually, considering the rise of telehealth services. And Kelly's going to take it away from here.
All right. So we began the process of our project by investigating 3 topics to build a foundation for our workshops and to examine a number of pressing issues facing DPT and PTA students currently. So, we split into 3 groups of 2 in order to broaden our scope. So the first literature review revolved around finding a tool that could assess student perceptions of virtual learning. The second literature review sought best practices in virtual education. The third literature review examined the change to and details surrounding telehealth. And let's go ahead and look at that first literature review. So with the first one, we had this broad shift to virtual learning. We wanted to find a way to assess the learner's perception of the virtual learning environment. So Ben and Emily found a tool created by Sanchez et al. Called the Web-Based Learning Attitudes Questionnaire. So after examining a number of tools in their research, and our group decided to use this tool due to the generalizability to all virtual learning platforms. We use Zoom. Some other programs may use something different, and we were also surveying PTA students. So the next cue, and with each one of these categories, the WBLAQ uses a Likert scale of 1 to 7 to assess each item. And the next slide shows the items assessed. And we can go into that more later if anybody else has questions. And then further down in the rest of this presentation, you'll see how we implemented this tool into our project. All right, for literature review number 2, Danny and myself looked at best practice in education. So a primary component of our project was to design effective teaching and learning workshops for PTA students. So we wanted to know what the best practices were for virtual education, given the high chance that they were going to be conducted online. So because of heavy emphasis on psychomotor learning in the healthcare professions, especially physical therapy, we looked at both cognitive and psychomotor domains. So in very, very short summary, we found hybrid, or sometimes called flipped classroom environment, showed the best outcomes for the healthcare student population, while visual aids are better than written aids for attempting to teach a psychomotor skill virtually. So of particular interest, so this last topic here, is that evidence show that the way learners perceive a virtual environment does not necessarily reflect their objective performance, which we found very interesting. And then in the last literature review we did, this one was conducted by MK and Tim. And we found that due to the pandemic, there was a necessary shift to telehealth for PT services. And we wanted to examine these changes and the evidence around telehealth for physical therapy. So they looked at the literature and found that regulations have both temporary and permanent changes regarding telehealth, and that it has found to be an effective method for delivery of physical therapy. And this is especially for populations that struggle with access. And importantly, it can lessen some of the detrimental impacts of social distancing, especially on older adults. So now I'm going to pass it off to Ben, and he's going to tell you more about our workshops.
So in addition to our literature reviews, we created 3 service learning workshops for this research project, and they were delivered to local PTA students at South College and Southwestern Community College. To create these workshops, our doctoral team of 6 students split into 3 teams of 2. Each team picked a topic of interest related to physical therapy, and then we developed lesson plans and objectives for each topic. We created pre and post tests based on each individual workshop's learning material. And then each pair of students delivered a 2 to 3 hour immersive workshop for each topic to select groups of PTA students. So all 3 of our workshops were conducted in a little different manner. Workshop number 1 was titled Pulmonary Interventions for the PTA in an Outpatient Setting. It was created by Danny and Emily and given to Southwestern PTA students. This project is created to be totally virtual in accordance with the COVID-19 standards at that time, which was last fall. Workshop number 2 was titled Biomechanics of the Shoulder and Structural Pathology in Rotator Cuff Tears. It was created by Ben and MK and was also given to Southwestern PTA students. This workshop was a little different. It was delivered in the hybrid form, which included the PTA students watching a 45-minute pre-recorded lecture and then coming in person to Western Carolina's campus for a 2-hour in-person anatomy and interventions lab. And then finally, workshop number 3 was titled Evidence-Based Interventions for Low Back Pain. It was created by Tim and Kelly, and it was given to South College PTA students. And this workshop was done completely in person. So right here, we just have some photos from our workshops. The left was from our hybrid session, the in-person portion, and then on the right was a screenshot from Danny and Emily's virtual workshop. So moving on to our materials and methods, the data that we collected for this research project was collected for 2 main purposes. The first was to examine efficacy of learning among PTA students who attended our team's workshops. And the second purpose was to record PTA student and DPT students' perceptions of virtual learning. To assess the efficacy of learning for the 3 workshops, we collected pre-test and post-test responses from the PTA students before and after they participated in our workshops. And these pre-tests and post-tests were based on the content of each of the workshops. And then we also collected pre-test and post-test data from a control group. And then afterwards, we analyzed the PTA data and control data using independent and paired t-tests. And then to assess PTA and DPT student perceptions of virtual learning, we used the WBLAQ questionnaire that was mentioned a little earlier. And we collected responses from both DPT and PTA students. And then along with that, we collected demographic information using a demographic questionnaire that we created. And that was looking at factors including age, gender, education level, income, and previous online learning experience. And then finally, we analyzed each demographic variable in relation to the WBLAQ scores that we collected using logistic regression, t-test, and ANOVA.
All right, so I'll go through the results here with you all. As Ben was saying, for our workshop efficacy measurement, our independent variables were really those pre-workshop and post-workshop content knowledge tests that we developed, and those were distributed to the PTA students before and after the workshop, as well as a group of DPT students who did not attend the workshop as a control. And of course, our dependent variables were the scores on those pre and post workshop tests. So as we go to the next slide, we'll see that all of our groups improved significantly from their pre to post test or post workshop test, regardless of the teaching method. So as Ben was saying, one workshop was delivered completely online, one was delivered completely in person, and there was a hybrid workshop. So it's interesting to note that all three, regardless of teaching method, improved. Now, as we go to the next slide and look at some learner perception variables, because this was an exploratory study, we really examined as many independent variables as we could to see if there was a correlation with their learner perception of an online environment as measured by the WBLAQ. So we looked at a lot of the demographic data, including program, year of the program, past experience with an online course, and that sort of thing. And what we ended up using as our dependent variable was scoring in the lowest quartile across the continuum of responses we received on the WBLAQ. So on the next slide, we'll show something interesting that we found was that PTA students scored slightly less on average than DPT students on the WBLAQ, suggesting that they have slightly less positive perceptions of online learning. So on the next slide, we'll show you what we decided to do with that information was run a logistic regression, because what we really wanted to do was see across the continuum of scores that we received from the WBLAQ, we wanted to see if there was a significant grouping of PTA students in the lower quartile of those scores. And we found there indeed was a significant grouping of PTA students in the lower quartile. So on the next slide, we have some of those percentages laid out for you regarding PTA versus DPT students who were in the lower quartile of those scores. And the take-home message really on the next slide is that PTA students were 2.69 times more likely to be in the lowest quartile of their WBLAQ scores compared to DPT students, suggesting that there really is a difference in how PTA students are perceiving online learning, and that they have slightly less positive perceptions of an online environment. So as we go to our conclusions, with regard to our workshop efficacy, we observed significant changes in pre to post workshop content knowledge as measured by our content knowledge tests, regardless of the workshop method. For learning perceptions measured by the WBLAQ, we found that PTA students scored slightly lower and had slightly less positive outcomes. And then we really want to think about applications to telehealth. So from the data we collected, we could infer that patients might have a lower or less positive perception of an online environment, but that doesn't necessarily mean that outcomes will be affected. And that's great. You can go to the next slide. So some areas for future research are really to further examine this relationship between learner perception and learning outcome and see to what degree, if any, learning perception in the online environment affects the outcome. And we also want to see if a perception might increase or become more positive with exposure. And of course, in the telehealth environment, we want to see if those perceptions are really going to have a drastic impact on patient experience and education. So with that, we just want to thank our faculty advisors and thank all of you all. And we look forward to your questions in the chat.
All right, great. We'll give our second group a round of applause. What questions do we have for our second group of student researchers? So we have a question from the audience here. Did the PTA students use any online format prior to the pandemic that may have influenced their perceptions?
We did ask about prior online experience, how many courses prior to the year 2020 that the students had, and we checked to see if that was a confounder, and it did not turn out to be a confounder in any of the statistics that were run.
Other questions for our second group? All right, well, with that, we will move into our third student group. Let's give another round of applause for our second group here. Our next project is entitled Pelvic Floor Dysfunction for the General Practicing Physical Therapist, presented by Daniel Jennings, Nina Wharton, Maureen Trey, and Shannon Gurney, sponsored by Dr. Douglas Keskula.
Can everyone hear me okay? Awesome. Welcome. Thank you all for joining us. With advisement from Dr. Doug Keskula and recent graduate Haley Hedges, Shannon, Daniel, Maureen, and I present to you pelvic floor dysfunction for the practicing physical therapist. As practicing physical therapists with more access to patients than ever before, it is our duty to ensure we provide well-informed evaluation and treatments for our patients. This involves having a general understanding of differential diagnoses and being able to recognize symptoms that fall within our scope of practice. Pelvic floor dysfunction is an important educational topic for the PT because it is something that we will encounter and may be linked to other conditions. Current reports of prevalence are around 25% in women and also occurs in men, but less frequently. These conditions can lead to social distress, isolation, anxiety, depression, embarrassment, and stigmatization. Since the pelvic functions are related to intercourse, urination and defecation, support and stability, as well as for the removal of blood and lymphatic fluids, these are often considered taboo subjects by the patient that lead to hesitation when discussing the subject with their provider. This presents a barrier to the PTs being able to provide the best quality of care to their patients. The intent of this presentation is multifaceted and is based on pelvic floor anatomy. The goal is to provide a greater understanding of this anatomy and the intricacies of the area. By building the framework in this manner, the learner should be able to better understand practical guidelines for patient evaluation, followed by proper management and treatment of both male and female populations. There will also be a focus on common presentations and how they relate to the musculature and surrounding areas. The overarching purpose is for practicing physical therapists to have foundational anatomy as their guide for optimal patient care regarding any number of pelvic floor dysfunctions. The learning objectives for this project should allow the learner to identify the anatomy, appreciate the small size of the area and its complexity, visualize the anatomy through the dissection images, understand the function of the pelvic floor, and discuss how this relates to the physical therapist. The following images allow for modesty and confidentiality of the donors used in our dissections.
In order to understand pelvic floor dysfunction, it's important to first understand pelvic anatomy. The bony pelvis is the staple base of the axial skeleton and is the attachment site for pelvic floor muscles, fascia, and ligaments. Muscles and fascia layer upon each other to create the hammock-like pelvic floor. These muscles are categorized into 3 layers, the superficial layer being associated with external genitalia and anal sphincters. The intermediate layer, or the urogenital diaphragm, contains muscles that assist in urination and sexual function. The deep layer, referred to as the pelvic diaphragm, contains the primary pelvic floor muscles, which are the levator ani and the coccygeus, and the pelvic viscera consists of urogenital, reproductive, and gastrointestinal structures. The levator ani is the largest muscle in the pelvic floor and is typically divided into 3 parts: the puborectalis, the pubococcygeus, and the iliococcygeus. The pelvic diaphragm is made up of 70% slow twitch fibers. These endurance fibers are important for maintaining resting continence and postural stability. The other 30% of muscle fibers are fast twitch and aid in reflexive continence, sexual function, and postural stability during sudden disturbances. The obturator internus and piriformis muscles, which are primarily hip stabilizers, also create a portion of the walls of the pelvic cavity and contribute to pelvic floor function. This is of clinical significance as this close proximity means that an impairment in length, strength, endurance, or recruitment patterns of the piriformis or obturator internus muscles can contribute to pelvic floor muscle impairments and vice versa. The pelvic fascia is an extension of the extraperitoneal connective tissue of the abdomen. The top right image displays how the abdominal fascia extends inferiorly into the pelvis. The pelvic fascia is interwoven with the viscera and musculature so that it functions and moves in accordance with these structures. The endopelvic fascia refers to the visceral fascia, which encases vessels, lymphatics, nerves, and organs. The parietal fascia covers the musculature and assists in attaching pelvic muscle to bone. It also acts as an anchor site for the visceral fascia. Thickened areas of parietal fascia form ligaments that assist in maintaining the position of pelvic organs. Examples of these ligaments can be seen in the bottom image. The cardinal ligament is found in females and attaches the uterus to pelvic bone. The tendinous arch, which is part of the obturator internus fascia, is the attachment site for part of the levator ani. Here you can see the female and male pelvis with their respective visceral structures. These images allow you to gain an appreciation of the position of the viscera and the depth of the various pelvic floor muscles. It also allows you to see how mobile these structures in this region need to be. For example, the bladder in the bottom image is expanded and extends more upward than the contracted bladder in the top image. You can also see the puborectalis, which is part of the levator ani, as it wraps around behind the rectum. This muscle is important for preserving fecal continence. The pelvic floor muscles have an integral role in many functions that contribute to overall health and wellness. They support the abdominal contents and maintain the position of the pelvic organs. They are important in controlling intra-abdominal pressure so that when we cough, sneeze, or laugh, our innards don't end up on the floor. They provide stability and aid in the transmission of forces from the lower extremities through the pelvis and trunk. They also have a key role in postural stability, and their contraction aids in maintaining balance when an external force is applied. The pelvic floor is the foundation of the core muscles and provides essential support for pelvic alignment and spinal stability. The sphincteric function refers to their role in providing closure for the urethra and rectum to maintain continence. During intercourse, the pelvic floor muscles provide proprioceptive sensation and are active during orgasm. In men, pelvic floor muscles assist in acquiring and maintaining an erection. Hypertonicity of the pelvic floor muscles can lead to pain with penetration. The sump pump function refers to the pelvic floor muscles' role in assisting in the upward flow of venous and lymphatic fluids.
For this project, 4 dissections were performed with 2 on males and 2 on females. The first 2 dissections removed the pelvic organs to reveal the underlying musculature, and the second 2 left the organs in. Through dissection, the intricacy of the pelvic floor was revealed. The pelvic cavity is small and holds numerous structures, making it a difficult space to navigate. The muscles and viscera of the pelvis are nestled deeply within the pelvic cavity and are encapsulated within the endopelvic fascia. Visualizing this interconnection enhances the implication that stress to any one structure is almost inevitably going to cause multistructural impacts. The complicacy of the pelvic anatomy means that palpation to identify impaired structures requires a high level of skill in addition to a significant understanding of the complex relationships between the structures within the pelvis. Performing the dissection reinforced the notion that proper evaluation and diagnosis of pelvic floor dysfunctions, which is discussed more in later sections, is often multifactorial and may require multiple healthcare providers. This team approach is often also needed for the treatment of these conditions. Dissection is crucial when assessing anatomical features that are difficult to distinguish from one another. The anatomy is the cornerstone of the evaluation, examination, and subsequent treatment of patients with pelvic floor dysfunction. No matter the population, being able to visualize the area is an invaluable tool that will allow for optimal patient treatment. These pictures from the dissection show how narrow the space is that houses the pelvic organs and fascia. Just taking the pictures was a challenge, trying to move things out of the way to get a view of the pelvic floor. The picture on the left shows the levator ani muscles. It's difficult to separate the different levator ani muscles along with the piriformis, which is located next to them. Seeing the close proximity of the pelvic floor to some of the hip musculature reinforces the concept that they'll influence each other, and damage or injury to one will certainly cause a change in the function of the other. The difficulties with differentiation of musculature through dissection shows the skill required to recognize different muscles with internal palpation of a patient. In an attempt to simplify the vast array of pelvic floor disorders that can occur, they've been categorized by low tone and high tone dysfunction. Low tone disorders are associated with soft tissue weakness, strain, tearing, denervation, and vascular compromise. The most common manifestation is stress urinary incontinence, which occurs with between 37 and 42% of women. This type of incontinence presents as leakage associated with increased intra-abdominal pressure, since the pelvic floor muscles are unable to counter these forces. The increased pressure can be from lifting weight, coughing, sneezing, laughing, or exercise. It can be caused by pregnancy and vaginal childbirth due to injury to connective tissue supports, compression damage by the fetus to pelvic vasculature, damage to nerves and/or muscles, and physiological changes. Other causes include ligamentous impairment leading to a dysfunctional urethra and/or sphincters, and congenital anomalies such as severe scoliosis, which can lead to neurogenic issues. Some less common presentations of low-tone dysfunction include fecal incontinence and pelvic organ prolapse.
Now moving on to discussing high-tone dysfunctions of the pelvic floor. These are characterized by persistent and elevated resting muscle tone. According to the International Classification of Disease, high-tone pelvic floor dysfunction is hypertonicity of the levator ani complex and pain upon attempted penetration, squeeze or palpation of the vaginal and pelvic musculature. The most common high-tone pelvic dysfunction is chronic pelvic pain, which affects 15 to 24% of women. Making this diagnosis is extremely difficult because pain in the pelvis may arise from the pelvic floor muscles, viscera located in the pelvis, or it could be referred from elsewhere in the body. So this is generally made as a diagnosis by ruling out the other potential causes of pelvic pain. Physical therapists are most likely going to treat musculoskeletal related pelvic pain, which may be secondary to trauma, such as falls, childbirth, or motor vehicle accidents, to name a few, or it could be caused by psychological abuse. Some of the less common diagnoses associated with high-tone pelvic floor dysfunction include levator ani syndrome and dyspareunia. To wrap up our presentation, a discussion of the implications of pelvic floor and pelvic floor dysfunction as relates to physical therapy is important. As a treating clinician, it is imperative to remain mindful of the sensitivity surrounding certain aspects of a person's health history. This is especially true when it comes to pelvic health due to the intimate and private nature of this region. This is not uncommon for patients to be embarrassed to openly discuss their pelvic health issues or reluctant to share any traumatizing experiences. Questionnaires are utilized to assist in uncovering pelvic disorders that may be difficult for a patient to address. An example is the initial measurement of patient-reported pelvic floor complaints tool, which analyzes the severity of fecal and urinary incontinence, lower urinary tract symptoms, sexual dysfunction, constipation, and pelvic organ prolapse. Another important tool to have as a clinician is screening questions for when a pelvic floor dysfunction is suspected. An example of 3 quick questions to ask are, do you ever leak urine or feces? Do you ever wear a pad because of leaking urine? And do you have any pain during intercourse? Additionally, it is necessary to understand that patients with pelvic floor dysfunctions present with a higher likelihood of depression. Due to these factors, it is important for the physical therapist to build rapport with their patients and address these sensitive topics with sympathy and understanding, while doing their best to educate the patient on how to manage their issues. Finally, the physical therapist should use their clinical reasoning to determine if they have the skill set to treat the patient or if a referral to a healthcare provider with more knowledge on the area is warranted.
And last but not least, here's a list of our references. If you would like an even more detailed and comprehensive review of what we achieved with this project, please reach out. We're happy to share our literature review with you. Thank you.
All right, excellent. Let's have a round of applause for our student presenters. Excellent work. Before we get to audience questions, I just wanted to address, I know there are a number of folks that just joined us. There is a program available in the chat as a PDF file. If you go down to the bottom of your Zoom window, you'll notice a little speech bubble icon that says chat. If you click on that, there will be a PDF that you can download that says Graduate Research Symposium 2021 that will have our full itinerary on it. Also, for those folks just joining us, I have defaulted the microphone to mute today. We'd ask that you maintain the mute on your microphone, but please feel free to provide comments or any questions you may have in the chat to each one of our groups of student researchers. And with that, we will take a look at some of these questions. The first question we have from our audience for our last group here is, are there screening questions that are more specific to men, or do you think the 3 questions you provided would adequately cover male patients?
So we did not find any that were more specific to men. In general, this project, we did find it difficult to find specific things for men because it's more commonly looked at in women. So at this point, there are not any that I am aware of.
All right.
I think those 3 screening questions, they came from our Brody and Hall textbook, which basically said that we should ask those questions if we're dealing with patients who have back issues or anything like related to the pelvic floor area.
Thank you. Our second question is, in the intro, it was stated that 25% of women present with pelvic floor dysfunction. Later, it was shared that 37 to 45% of women have stress incontinence. Can you please help us understand the difference between these statistics?
Okay, so with the first number, the 25%, that is pelvic floor dysfunction across the board. So when you further go into that number, that's where the 37 to 45% comes in. That number is strictly for stress incontinence.
Thank you. The next question we have is, did you find anything interesting or shocking during the dissections that you can share with us?
Daniel, do you have anything to say about this?
Yeah, I guess I'll just say you have to be really careful when you're dealing with the rectum and colon, and it's a very sensitive area that can sometimes open up unexpectedly.
Thank you. Our next
There
question
was also something when we were dissecting one of the male donors, we found, which this is totally off. We don't know for the record what this structure was, but it seemed to be attached to one of his testicles. When we followed the soft tissue up, there was like a harder structure up in his lower abdomen. So it almost looked like it could be a 3rd testicle, but we don't know what it was. We had asked, there was a surgeon there working with us, and he had never seen anything like it, so he didn't know what that was.
Thank you. Our next question from the audience is, did you come across anything about Ehlers-Danlos syndrome and its impact on pelvic floor dysfunction? Looking at the anatomy, particularly the amount of fascia connective tissue in the area, it seems as if someone with a connective tissue disorder should be screened for pelvic floor dysfunction specifically.
I didn't see anything specifically
I didn't
about
either.
Ehlers-Danlos. That's a good question, though.
Yes, thank you. Another question is, did you find any prolapse, rectal or vaginal, in any of your dissections?
No.
We have another question coming in here. Are patients usually referred from the primary care provider to physical therapy and then from there to a pelvic PT specialist, if that is their primary or chief complaint? Or do they typically go from a primary care provider to specifically to a specialist PT in that practice area?
I think it would depend on the situation, but I think if the primary care provider is aware that specialists exist in pelvic floor physical therapy, they would make the direct referral. But if they're unaware of it, which isn't uncommon for them to be unaware of it, then they might just refer to PT. But I imagine if they think that PT can help, they would probably be aware that that exists.
Thank you. I think this audience member is curious about your thoughts on how much pelvic physical therapy training should go into a general physical therapy curriculum, such as the one you're currently in, versus a specialty education.
So I think the general thought that we had come to a conclusion with as a group is that a good amount should be in there just so that we can at least recognize red flags and be able to recognize when the pelvic floor could be involved, so that we can either, if we want to go specialized, we can become specialized in this area if we find it fascinating and interesting, or we can then know resources that we can then refer this patient to if we are if it's above our scope of practice or above our comfort level.
Excellent. Thank you. And Dr. Hudson is chiming in here to suggest that second year students will have 3 full days of pelvic health this summer. And we have our last question from the audience here because we are near our time limits. This question is asking, do you think with sufficient trauma-informed care background, an average physical therapist, maybe without additional pelvic health training beyond that offered in an entry-level program, would have the skills necessary to address pelvic floor issues? Or do you think that it is always appropriate to refer to a specialist with these patients?
I think that with trauma, it could be beneficial to have them be seen by a specialist, especially because intravaginal examination is the best way to learn how everything is happening and how to fix the problem best. There's biofeedback that a lot of people use, but apparently that's nowhere near as productive as doing the actual internal exam, and only specialists can do that.
Excellent, thank you. Well, let's give this group another round of applause. Very good, and we have one more group to go here before our intermission. This next project is entitled Helping Hondurans Stay Active During the COVID-19 Pandemic. The graduate students presenting to us today are Courtney Dedea, Haley G., Kim Avalos, Kyle Donaldson, my apologies, Alex Miller, Bianca Baru, Fran Toller, Bailey Cloninger, Kaylee Mathis, and Madison Vaughn, with faculty sponsors Dr. Todd Watson and Jessica Granning.
Thank you for joining us today for this presentation. There's been a lot of hard work that has been put into this project, and we're excited to share with you. Our doctoral project was on addressing the health disparities in Honduras during the COVID-19 pandemic. During this presentation, we're going to talk about what we did to meet the needs of the people of Honduras, why it was so important for us to address the health disparities in this country, how we accomplished those goals, challenges we faced along the way, as well as talking about future goals to carry forward. Talabay is a beautiful small town located in central Honduras filled with culture and energy. The total population of Talabay is a little over 24,000 people. This town suffers from very high levels of poverty and limited access to basic needs. 48.3% of people live in poverty in Honduras, and the percentage is higher for people that live in rural areas like Talabé. That's 1 in 5 people living on less than $1.90 US dollars per day. The people of Talabé are hardworking people that primarily have very laborious and physically demanding jobs. With limited access to healthcare and decreased health literacy, the challenges their community face is what drove Western Carolina University's doctoral physical therapy program to start initiatives to battle the decreased health literacy and healthcare.
Western Carolina physical therapy students have been traveling to Talabé, Honduras to provide physical therapy services since 2013. Initially, our professor, Dr. Todd Watson, started going to Talabé with his family in 2011. After seeing a great opportunity to serve others while expanding the experiences of the students, medical mission trips to Talabé soon became a regular occurrence in the program each year. Dr. Watson was able to develop a relationship with the clinic located in Talabé. Sylvia Palada, a nurse at the clinic, has been in communication with the physical therapy program throughout the years to help us get a better understanding of the needs of the people in rural Honduras and how we can help meet those needs. Sylvia has been an invaluable addition in the collaboration of this doctoral project, as well as a huge part in advancing and promoting healthcare services in her area. Last year was the first year the annual trip to Honduras was also used as a research opportunity for the physical therapy program. Students seek to gain further understanding of the culture and general health of the communities in rural Honduras. They developed a set of resources that would help empower community members to better understand how to maintain healthy lifestyles. The team created interactive presentations and workshops to host in-country for the health promoters and community members. The topics for the presentations were based on a needs assessment performed with local community partners. One workshop provided education on cardiac health, focusing on risk factors for hypertension, the effects of hypertension on the body, and how exercise impacts heart health. Each participant's blood pressure was taken at the beginning of the presentation to help them better understand how the information applied to them. Another presentation was created focusing on the benefits of exercise, the different types of exercise, as well as general dosage. Participants were taught different exercises that could be performed without equipment and engaged in a cardio dance portion that was created to be more culturally appropriate. The final presentation was about nutrition and focused on healthy foods in the area, how to portion control using your hands, and specific information for pregnant women and individuals with type 2 diabetes.
Last year's group collected a few demographics specific to the people of Talabé and those who attended their clinic. These included age, BMI, gender, 6-minute walk test, 30-second chair rise, chair sit and reach, and timed up and go, otherwise known as the tug. The 6-minute walk test provided data on heart rate and blood pressure of the individuals. The average age of these participants was 74 years, and there were 41 participants. The average BMI was 29.56, and there were 9 male participants and 32 female participants. The 6-minute walk test, 30-second chair rise, chair sit and reach test, and tug were all used to determine how the participants compared physically to their age-matched norms. For 6-minute walk test, there were 2 groups, with the second group being generally younger than the first. Their blood pressure and heart rate were taken at the beginning, then they were instructed to walk for 6 minutes at their normal speed. The first group averaged 185 meters, and the second group covered 425 meters. Blood pressure and heart rate were taken again at the end to determine the change of each from start to finish. 100% of both of these groups were below their age-matched norms, indicating that they have decreased endurance. The 30-second chair rise was used to assess lower extremity strength and endurance. 42% of females and 38% of males were at fall risk, according to CDC normative values. The chair sit and reach test was used to measure hamstring flexibility. The results demonstrated significantly decreased hamstring length. The tug was used to assess fall risk of individuals respective to their age groups and norms. A tug score of greater than 12 seconds indicates a fall risk, and 35% of individuals were at increased risk for falls. Following the collection of this data, WCU DPT students created a satisfaction survey and video series on exercise for individuals' specific health conditions such as diabetes, hypertension, osteoarthritis, anxiety, obesity, low back pain, as well as exercise for minors.
COVID in Honduras is impacting access to healthy lifestyles and what we can do as a PT program to help. The initiation of this project first began last year with the goal of addressing the health disparities in Talabé, Honduras. They focused on educating healthcare professionals and patients of the risk of hypertension in Honduras and developed interactive exercises to motivate the community to stay active. COVID changed the health status of numerous people of Honduras and our ability to continue the research as originally planned. The big questions we had to ask ourselves were, what resources can we provide, and what are the barriers we need to overcome? Our focus changed from interactive exercises and in-country treatment to providing safe and effective strategies and options for exercising at home and establishing a telehealth network with the people of Honduras.
As a group, we met with Sylvia Palada, a nurse at El Centro de Salud Clinic in Talabé, to find out how we could best serve her community. As for many, COVID-19 has given rise to a sedentary lifestyle for the people of Honduras and exacerbated health conditions such as obesity, hypertension, high cholesterol, and diabetes. Secondly, Sylvia mentioned certain barriers that Hondurans face in their homes that helped us determine the best way to provide exercise materials to them. These included a lack of internet, lack of televisions, and lack of exercise equipment, as well as strenuous daily work conditions. After our meeting with Sylvia, it was decided that the best way for us to serve the local community of Talabé was to create a workout program and provide the Hondurans with ways to stay active during the pandemic. Our team created deliverables for the people of Talabé so that they could have access and information about the workout program that we created for them. Among these were an infomercial to be played in local clinics, a brochure with the exercises written out for those who do not have access to a television, and lastly, an exercise video including a few of our team members performing a high-intensity interval training workout with progressions and regressions of each exercise so that a broad range of individuals could follow along no matter their current fitness level.
We decided that an infomercial would be the best way to quickly educate the people of Talabé about the importance of physical therapy in general, as well as why it's important specifically during the COVID-19 pandemic. This presentation goes through the effects of COVID on an individual's health and gives examples of activities and exercises to stay active while staying safe. We also designed some basic workout plans. This video will be shown in waiting rooms at local clinics in Talabé, allowing people to watch while waiting. The presentation also encourages the people watching to ask about other deliverables like the workout video and the brochure.
Another project deliverable is an exercise video. This video was created by our project group and features our very own WCU DPT students leading the workout. The workout features exercises in a 30-minute circuit style or HIIT design to be done at home with minimal equipment. The video also goes over progressions and regressions of each exercise, which are not included in the brochure. The video will be given out in the form of DVDs at local clinics in Talabé, Honduras, in the hopes that people who see it will be inspired to work out at home. Alternatively, the video will potentially be played on local television and available online through WhatsApp for the people who have access to internet. Our last project deliverable is a brochure that includes a circuit-style workout with 8 exercises, a suggested walking program, and education about why it is important to stay active during COVID-19. This brochure was designed to go along with the exercise video we created and features the same exercises in each. The purpose of creating a brochure is to reach more people who may not have the ability to play the video version of the workout at home with minimal equipment. Copies of this brochure were sent to Talabé, Honduras, and were made available in local clinics in that area for patients to take home with them and use as a guide for exercises to help them stay active. We wanted to make sure the brochure was as user-friendly as possible by taking into consideration a wide range of health and exercise literacy levels. Including a picture of each exercise helps make the brochure more accessible to the general public by visually describing exercises if they were not familiar with the wording of them. We wanted to make sure that the local community understands the importance of staying active, and we hope that the people of Talabé will use this resource to help them stay active during the COVID-19 pandemic.
We faced several barriers when deciding how to best distribute our deliverables. Normally, we would be delivering these materials to Honduras in person when we travel there. However, due to COVID and the consequential travel restrictions, we are currently unable to travel to Honduras. Additionally, we were initially unable to find other groups that were planning to travel to Honduras that could potentially take the materials for us. Regardless of COVID, there are several barriers in Talibé that also make distribution challenging. For example, they don't have a postal system in place. This prevents us from mailing our brochures or DVDs with our videos to the people or clinics in Talibé. Also, as previously mentioned, internet access is extremely limited, especially in people's homes. This means that creating a link or file to share isn't an option either. With all of this in mind, we decided it was best to send all 3 deliverables to Sylvia via email for her to distribute to local clinics. The clinics will be able to show the infomercial in waiting rooms, allowing patients to watch and learn while waiting to see their healthcare provider. The healthcare workers at the clinics will then distribute the workout video and brochure to patients as applicable. Some avenues we've discussed are showing the exercise video on a local television station, sharing the deliverables on WhatsApp for those that have internet or cell service, and making DVDs with the video on it. Recently, Jim Pierce of Honduras Fountain of Life, a US-based partner of Fuente de Vida, took roughly 200 copies of the brochure to Honduras for us. Here are some pictures of the people in Talibé with our brochures.
Due to the pandemic and travel restrictions, we are still awaiting results to see how effective the deliverables we created are for the people of Talibé. A survey was created to assess which deliverables were used, who were they used by, and to determine the level of difficulty and effectiveness each deliverable had. This survey included 8 multiple choice questions, some with a fill in the blank other option, and 2 open-ended questions to provide us with feedback and future project ideas. Questions were provided to give details on the population sampled, including their age, gender, work status, and any health concerns that led them to our program. These concerns included prevention of heart disease, management of diabetes, management of obesity, being physically active during COVID quarantine, or the option to add others. The effectiveness was scored based on a 5-level scale ranging from extremely effective to not effective. The level of difficulty was scored based on a 5-level scale ranging from extremely easy to very hard. This survey was translated to Spanish by one of our bilingual team members. The plan for distribution is to include a link to the survey for users with internet access and to provide the local clinic with paper copies for those who do not.
Although COVID impacted what we could do in person for the people of Honduras, it allowed our team to become creative and expand the impact we could make from afar. Over the summer, our program started providing telehealth physical therapy services in order to combat the pandemic's effect on our patients from the Mountain Area Pro Bono Clinic. We were unable to treat in person, but that didn't stop us from finding ways to provide them with accessible care. The same applies here. Even though we may not be able to provide the people of Talibé and surrounding areas with our hands-on services due to COVID-19, that won't stop us from helping them over telehealth. To our knowledge, Western Carolina University's Doctorate of Physical Therapy program will soon be the first university in the country to provide international telehealth services. Expanding into telehealth will allow PT services to be more accessible to the people of Talibé. Access to internet and telehealth services will also increase opportunities to educate the population on health through the combination of this year's team exercise deliverables and last year's educational materials on cardiac health, hypertension, nutrition, and type 2 diabetes and nutrition for pregnancy. Our hope is to continue to update and create educational health materials and collaborate with other fields as this project grows in the coming years. We are proud to continue this tradition of serving the people of Talibé, Honduras, and are so excited to start introducing new ways to help meet the needs of Hondurans.
Nos gustaría agradecer al Dr. Watson y a la Dra. Granil por su soporte durante este proyecto y su optimismo durante estos tiempos difíciles. Nos gustaría agradecer a Auxiliadora García por traducir el texto del video de ejercicio para disminuir nuestras barreras lingüísticas para la comunidad de Honduras. Gracias a Jim Pierce, un socio estadounidense de Fuente de Vida, para enviarnos nuestros folletos a Silvia para ayudar a distribuirlos en las clínicas de Honduras. Gracias a Eric Smith por trabajar en nuestro video de ejercicios para que luego podamos distribuirlo a la comunidad de Honduras. Y también queremos agradecer a Silvia Palada y a la comunidad de Honduras. Sin usted, nada de esto sería posible. We'd like to thank Dr. Watson and Dr. Granning for their continual guidance through this project and optimism during these hard times.
We'd like to thank Auxiliadora Garcia for translating the exercise videos script to decrease our language barriers for our community in Honduras. Thank you to Jim Pierce of Honduras Foundation of Life for sending our brochures to Sylvia to help distribute them in the clinics of Honduras. Thank you to Eric Smith for working on our exercise videos so we may later distribute that as well. And thank you to Sylvia, Palada, and the people of Honduras. Without you, none of this would be possible. Thank you.
Excellent. Let's have a round of applause for our student researchers. All right, what questions do we have for this group? So an audience member wants to know, does your team plan on assessing adherence rates to the exercise programs?
I can't remember if that's in the survey that we are sending out to everyone, but if that's not, that is definitely something that we could look at in the future, especially when we're in country and we can see people's reaction to the materials that we've been given to them.
Thank you. The next question is, are the age match controls referenced, are those groups country specific? And where do those norms come from?
If Danny's talking about the statistics from last year, that would be from when the now third years went to Honduras last year and gathered that data. And so that's where we got all of the numbers from.
Most of the age match norms that we used were just from the CDC.
Excellent, thank you. Our next question is, how many clinics have the materials currently been dispersed to?
I believe that they've been dispersed to 3 clinics so far, or that's our goal via Sylvia and Jim Pierce.
Thank you. Our next question is, do citizens have no way of receiving mail in Honduras?
I'm pretty sure that what we talked about with Dr. Watson is that they have like a system set in place where they can go and get mail, but they don't have anything that comes directly to them. So like for them to travel and get mail, it's like could be hours away from their home to go and get what they need.
Thank you. Our next question is, are there plans to expand the reach of this program to other cities and countries in Honduras and Central America?
We are starting off with Honduras first, so we'll see if that works first.
And I will add, whenever the team before us went to Honduras, there would be people that would travel from hours away to get physical therapy services. So in one way to look at it, we are helping surrounding areas that are close to Talibé as well. But yeah, definitely starting out with this particular area.
All right, very good. Other questions for our student researchers? We have one coming in now. Are all 3 of those clinics able to use telehealth? Is this something that could be a potential partner with all clinics? So I guess expanding beyond the 3 that you mentioned.
So we are currently trying to get grants and the telehealth set up for one of the clinics. And then depending on how that goes, we're gonna for sure expand to make sure that all 3 clinics can get the telehealth services.
Thank you. Is there a trip planned for 2022? That may be a question for Dr. Watson.
I think the plan right now is we're all hoping that we can go during winter break this year. So fingers crossed.
Yes, definitely want to get everyone back in country as soon as possible. That is a very valuable service learning opportunity.
Can I add just a response to that? I don't know.
Yes, please, Dr.
How well Dr. Watson is feeling right now after his vaccine. We're waiting on approval to travel. And so that's going to depend on the university. And so this year's group is planning on hopefully having the travel course, over winter break. But as long as everything returns to normal, the space occurs in the curriculum during the mini-mester of the second year to allow for this independent study travel course. So hopefully, fingers crossed, that will resume in 2022.
Thank you very much, Dr. Grannon, for your input on that. Other questions? All right, well, that brings us to the midway point of our session this afternoon. So we will now take a 15-minute intermission, and then we will come back and start up with our fifth group. All right, welcome back, everyone. We will now start the second half of our program with the project entitled The Effects of Focus on Attention on Functional Movement and Motor Learning in Individuals Post-Stroke, presented by Ann Gallagher, Abby Murrell, Carly Ryman, Tyler Steele, Haley Wright, and sponsored by Drs. Ashley Hyatt and David Hudson and Kim Hudson, Master of Science.
Hey everybody, thank you Dr. Eckert for the introduction. There we go. To begin, we would just like to address that the information we are presenting on today is part of an ongoing research series, and most of this information is specifically regarding the reliability and validity of one of the pieces of technology that we used for data collection. And we will also discuss future directions for research on this topic later in the presentation. So a little background and introduction on why this study is relevant. Stroke is the #1 cause of long-term disability in the United States, and it affects or impacts approximately 795,000 people every year. There has also been a recent proposal by the Center for Medicare and Medicaid Services, which provides coverage for a large portion of this population to reduce reimbursement rates for PT services by 8%. With this potential reduction in reimbursement, it is more important than ever to focus on the efficacy and efficiency of the care that we provide for this population. We will discuss more later in the presentation, but this makes the choice of language that we use, whether that's for instruction or feedback, highly important when considering the impact it may have on improving outcomes in this population. So here are a couple of definitions of the different foci of attention, both external and internal focus. An external focus is when the performer's attention is directed to the effect of the action itself. So a good example of this is when shooting a basketball, a person would focus on the hoop while shooting the basketball. And then an internal focus is when a performer's attention is directed to the action itself. So using that same basketball example, this would just mean that that person would focus on extending at their elbows and at their wrist while shooting the basketball. Here are a couple of the primary theoretical explanations for attentional strategies that you'll find commonly cited in the research. Both the constrained action hypothesis and the conscious processing theory are included commonly throughout the research. And the constrained action hypothesis basically says that thinking about your body impairs automatic movement. And then the conscious processing theory simply states that thinking about your body with an internal focus overloads your working memory and impairs implicit control of movement.
All right, so we looked at some studies looking at what kind of focus of attention PTs are using. So in one study, PTs in the UK that had worked in a neuro setting for at least 1 year were using these type of focus of attentions. And so on average, verbal instructions and feedbacks were made every 14 seconds. So in another way, on average, 76 instructions and 22 feedback statements were given each treatment session. And unfocused statements such as "good job," "keep up the good work" were frequently made. So within the study, you can see that about 67% of feedback and instructions were internal, and then external was about 22% of this. Then within another study, PTs in the Netherlands had advanced training in neuro-PT, and these PTs were found to use more external focus for patients with a longer length of stay and for patients with a stronger internal focus preference. So it needs to be, this kind of shows that patient preference does need to be taken into account with. So as you can see with this pie graph, feedback was about 37% of the statement types, instructions 30%, and others was 32%. So these are some sub-pie charts of the previous study, of the same study. And so with feedback, you can see that a lot of it, the attentional focus was unfocused at 64%. Internal came in at second with 19%, and external was 13%. So, and then looking at instruction, attentional focus, once again, majority was unfocused. External was about 29%, internal was 18%. So these pie graphs just really highlight the number of unfocused statements, and it just really further highlights Tyler's point that we need to be cognizant of our choice of language so that we can help improve outcomes in our patients and make the most of our treatment times, especially since Medicare is proposing a coverage cut. So previous research and attentional focus showed that in healthy populations, external focus seemed to be more effective than internal. And within these healthy populations, when the external focus was further away from the body, it seemed to be more effective. And within these healthy populations also, external focus was more effective in high anxiety and dynamic balance tasks. So within these healthy populations, adults and students seem to benefit more from external focus. And then children and athletes who participated in form-based sports, such as gymnastics, benefited from internal focus, as well as beginners learning basic coordination patterns. And this was found with over 80 studies that had looked at various populations.
Okay, so the research in the stroke population is limited and contradictory when looking at what focus of attention is best. Some found that an internal focus is more effective than an external focus at producing smooth movements, while others found that external focus was more effective with trunk control, VR tasks such as soccer with dynamic posture control, gait, and anticipatory postural adjustment task. But for balance board stabilization tasks, the study looked at long-term effects of either internal focus or external focus instructions, and there was no benefit of using one over the other.
We also wanted to address the limitations in research. Despite the studies Haley mentioned, there is still limited research within the stroke population. The study from Call et al. Was the only one that looked at the long-term effects, and they found no difference between the external and internal focus of attention groups. So more research is needed with retention trials to see if there's any evidence of motor learning. Additionally, there was a lack of functional movements, and several studies did not look at the quality of movement. The purpose of this series of studies was to explore focus of attention further within the stroke population and their motor learning through retention trials. The research question was, in the acute stroke population, does an internal or external focus of attention strategy lead to better motor learning during a seated lateral weight shifting task? The studies conducted in the first part of the series use Bodyline Pro to calculate various angles throughout the body. So the purpose of this most recent study was to determine the validity and reliability of the Bodyline Pro technology in analyzing trunk alignment and shoulder angles during seated lateral weight shifting. Results from Bodyline Pro were compared to findings from a 10-camera Qualisys motion capture system, which is considered the gold standard. Our first hypothesis is the Bodyline Pro will have good to excellent intra and inter-rater reliability. Our second hypothesis is the Bodyline Pro will have good to excellent criterion validity when measured against the gold standard, a 10-camera Qualisys motion capture system from Göteborg, Sweden.
All right, now I'm going to discuss the prior study protocol. So we were looking at lateral seated weight shifting ability in participants in an inpatient facility following a stroke. The participants were randomly assigned to either internal focus of attention instructions or external focus of attention instructions. The external focus group was instructed to align the markers on their acromion with a target that was positioned to their side at the height of their shoulder. The internal focus group was instructed just to lean their shoulder as far as they safely could. Outcomes were measured at baseline acquisition, short-term retention, which was 5 minutes later, and long-term retention, which was 7 days later. The results showed that external focus of attention is more effective in acquisition, but did not show carryover during retention trials. The equipment we used for this study was a body track pressure mat, which was placed under the participant to measure weight distribution during the lateral weight shift. And we also used Body Align Pro technology to measure the tilt angles of the shoulders during weight shift. The use of this technology is what actually sparked our most recent research question into how valid and reliable Body Align Pro technology is. In addition, we used markers and targets for the external focus group to provide a target. Here you can see how Body Align Pro technology works. The 2 dots are aligned on the acromion and 1 line is horizontal to see the tilt angle. So you can see 18 degrees, what 2 degrees and 1 degree looks like. And the methods for our most current research study, the Body Align Pro technology and 10-camera Qualisys motion capture system were used to analyze body alignment and shoulder angles of participants performing lateral seated weight shift. The participants were all seated on an adjustable plinth to ensure hips and knees were flexed to 90 degrees. All the participants were given the same instructions on the correct way to laterally weight shift, and the researcher demonstrated the movement for all participants. They were instructed to lean to each side as far as they safely could 3 times, totaling 6 trials. Researchers analyzing the data in Body Align Pro were blinded to the purpose of the research study.
So for the results of our current study, we found it to have excellent inter and intra-rater reliability with an interclass correlation coefficient of 0.999 and a p-value of less than 0.001. We also found it to have excellent criterion validity when measured against the gold standard of the movement analysis system at the same time and at the furthest lateral lean with an interclass correlation coefficient of 0.989 and a p-value of less than 0.001. So we found that the Body Align Pro was found to have excellent inter and intra-rater reliability and excellent validity. We believe that this equipment should be considered as an affordable and accessible alternative for data collection in a clinical setting, and the body markers should be used to optimize accuracy and validity. Some of the limitations of our study was that we only looked at seated lateral weight shifting. This equipment was found to be reliable and valid in the frontal plane in a healthy population, so we only looked at one plane and one population. And then some of the study analysis was done on the computer and some was done on an iPad. So future directions for our study, we believe that a reliability and validity study of the Body Align Pro in individuals post-stroke would be awesome. A crossover randomized study will observe the effects of having either an internal focus of attention or external focus of attention during repeated sit-to-stand training on lower extremity strength, function, and gait parameters. The goals of this study are to see if one focus of attention is more effective than the other in sit-to-stand training, and if carryover is possible with more frequent training sessions. We wanted to say thank you to our faculty advisor, Dr. Hyatt, Dr. Hudson, Kim Hudson, our participants, and to everyone for listening.
All right, thank you very much. Let's give this group a round of applause. What questions do we have for our student researchers? All right, we have one coming in here. I think it was stated that external focus was greater during high anxiety. Can you please give an example of that or potentially explain that a little bit further?
Yeah, so one of the studies that was done that looked at high anxiety was basically participants had to perform a task, and then the high anxiety was they were somewhat judged by their peers. Their scores were put on a leaderboard. And so it was more, I guess, peer, peer, what's the word I'm looking for? Peer judgment that was part of the high anxiety.
Thank you. Other questions for this research team? All right, well, let's go ahead and give this team another round of applause. Very good, and we'll move on to our next project here entitled, What Balance-Related Biomechanical Changes Occur in the Lower Extremity Due to Physical Fatigue, presented by Blake Garib, Connor Blanton, and Cameron Dellinger, sponsored by Dr. David Hudson.
Does Fatigue Affect Balance? A Scoping Review by Dr. David Hudson of the Physical Therapy Department, Blake Garib, Connor Blanton, and Cameron Dellinger. The review process included a EBSCOhost database search, including the keywords listed below, along with a 15-year ban, which led to a finding of 952 articles. In the abstract screen, inclusion criteria of a pre-test, post-test fatigue protocol and a valid balance measure were used. And in the full article review, articles were included if they had a valid experimental design. This led to 120 articles for the title screen and 21 full review text. The operational definitions of fatigue were mainly the four that are listed below. Max voluntary isometric contractions, where the researchers considered a muscle fatigued when it can no longer reach a certain percentage of the muscle's maximum voluntary isometric contraction. Moving through available range, the researchers considered a muscle fatigued when they could no longer move through the range or the participant could no longer keep up with a metronome. The Bruce protocol was the only cardiovascular fatigue method used and is a treadmill protocol. And EMG data was used to determine whether a muscle was activating at a certain percentage.
I think we may have an audio issue there. Blake, are you able to unmute yourself? Let's see. Blake, are you able to continue? See, I'm not getting an audio feed there. I'm sorry. Let's see, is someone else able to continue the presentation here? Or it looks like, Blake, you may have audio now. Are you able to? All right. Can we try to screen share and pick up where we left off there?
Yes, okay. I think Connor's got it now.
All right.
Or I can give it a shot.
Whatever is easiest from your group there. I am not getting a strong audio feed. I don't know if I'm alone in that, but is it able to get the volume a little bit higher or to try another feed?
In laboratory-based studies, they took a more technical form of measurement through utilizing a force plate. This allowed them to look specifically at ground reaction forces, postural sway, center of pressure, and the displacement of the center of pressure. These various balanced assessments gave the researchers insight to the changes that occur with anticipatory postural adjustments, automatic postural reactions, variability in postural sway in the anterior-posterior direction and the medial-lateral direction, and changes in the center of pressure that occur after the fatiguing protocols that Connor previously mentioned. Taking a closer look at the clinical-based assessments for balance. First, at the functional reach test. In this test, the individual will stand with an upright posture against the wall with a measuring device on it. They will then extend their arm out in front of them while maintaining this upright posture, and their fingertips will be used to take an initial measurement. The individual can then lean forward as far as they can while continuing to reach out, making any postural adjustments that are necessary to maintain their balance during this process. A second measurement can then be taken, again using their fingertips as the marker. The initial measurement can then be subtracted from the final to obtain the proper measure of how far the individual can reach out in front of themselves while maintaining their balance. The researchers were able to then reassess this test to identify any changes that occurred after fatigue was induced. Moving on to the lower extremity reach test. In this test, the individual will be standing on one leg. The other leg will be used to reach out in 3 directions to allow the researchers to obtain measurements. The directions that are involved in this test are the anterior direction and the posterior lateral direction to each side. The individual will reach out with the raised lower extremity as far as they can while maintaining balance on the stance leg. The researchers will record the measurement with each direction as the participant completes them. This will be retested after fatigue has been induced to assess for any changes that occur. The single leg stance time trial was also used in the clinic-based studies. This test simply consists of the individual standing on one lower extremity while the researcher assesses how long the participant can maintain their balance. These times will be recorded for comparison with post-fatigue test results. Taking a closer look at the laboratory-based assessments of balance, the researchers were able to utilize a force plate to look specifically at ground reaction forces, center of pressure, and postural sway. This allowed the researchers to analyze what areas of the foot were responsible for the distribution of weight during balance. The point that has the highest amount of force going through it is known as the center of pressure. During balance, the center of pressure is dynamic and moves around in conjunction with the individual's center of mass. This movement contributes to postural sway, which is the movement that is naturally occurring while maintaining balance within a parameter known as the individual's cone of stability. The cone of stability refers to the limits of postural sway. When an individual is able to stay within their cone of stability, they can maintain balance, but when they have excess sway, then they are unable to sustain their stability. With the use of a force plate, these measurements of ground reaction force, center of pressure, and postural sway can be mapped out and recorded for comparison between pre-fatigued and post-fatigue states of the study participants.
So how does fatigue affect balance? So far, the research that has been reviewed has identified a few positive and negative trends. In summary, this has included a decreased ability to react to an unanticipated response to external perturbations, and that the body will find the most optimal route to adapt to these stimuli. The research articles identified a decrease in automatic postural reactions, ability to adapt anticipatory postural adjustments, decrease in step length from a reactionary response, and postural sway. Additionally, a pattern of increased knee flexion moment, distribution to non-fatigue musculature, co-contractions, and again, postural sway have been identified. There's been some variability in how participants of the study adapt to fatigue when looking at postural sway, where the exact criteria that causes a change has not been identified in this review process at this time. This was first observed in a study performed by Ritzman et al., where they found an increase in co-contraction and decreased postural sway after fatigue. The study utilized 2 different fatigue protocols, one being perturbations until exhaustion in single leg stance, and the other being a volume-matched control protocol. The protocols were stopped after a subject was unable to maintain balance in 50% of a group of 4 perturbations. their data revealed statistically significant results in the exhaustion group, but not the volume-matched control. Here you can see the EMG data showing the increase in co-contraction of proximal to distal muscle groups with increased fatigue. Center of pressure displacement data shows a statistically significant decrease based on the researchers' p-value of less than 0.001 after a multivariate ANOVA, which is shown here. Salavati et al. Observed increased postural sway after isokinetic fatigue of the ankle inverter everters and hip flexor extensors. This was used to fatigue muscles in different movement planes and to compare distal to proximal muscle fatigue. They utilized excursion data via a moving force plate to quantify the amount each participant moved within each plane. They found an increase in postural sway with both proximal and distal muscle groups as well as movement planes. This may aid in predicting direction of instability based on muscle groups that are fatigued clinically. Here we can see the machine the researchers used to cause perturbations where the plate this lady is standing on will move beneath her. Additionally, here is graphs of the data collected by the researchers that show a greater increase in anterior, posterior, and medial lateral excursion after distal musculature fatigue as well as the movement plane changes post-fatigue. One study in this review observed a decrease in automatic postural reactions after a fatigue protocol and found a delay in the timing of EMG data for their selected postural muscles after moving from dumbbell limb to single limb support. This was performed by Aurora et al., where they looked at the effect of a fatiguing protocol on the balance of a non-fatigued contralateral limb. This was to assess the effect of muscular fatigue on CNS motor control. To induce fatigue, participants were asked to perform isometric knee extension until they could only achieve 50% of their baseline MVIC. While their study found no difference in balance of the non-fatigued limb, a statistically significant decrease in F100 force of the fatigued postural muscles was identified. As F100 force is the amount of force produced by a muscle in the first 100 milliseconds of MVIC, this may suggest a decreased response time to a perturbation during a balanced task when fatigued. The picture on the left shows how the isometric knee extension was performed, and the right shows the change in F100. Additionally, a decrease in step length after fatigue was observed in two studies, one performed by Pepe et al. And the other performed by Medemli et al., suggesting a decrease in postural reactions post-fatigue. Protocols for fatigue in both studies aimed at fatiguing the quadriceps and hamstrings. In the study performed by Pepe et al., subjects were considered fatigued when they reached 30% of their baseline MVIC. Medemli defined fatigue when participants could no longer go through full range of motion on their leg extension and flexion machine. After the control and fatigue procedure, the participants in both studies participated in a tether release protocol where they were asked to lean forward and backwards outside of their cone of stability while tethered to a rope about chest high. They were then released from the tether unexpectedly and expected to respond with a step. Appropriate safety precautions were in place, just to be clear. In addition to decreased step length, Papa et al. Identified a decrease in step velocity, specifically in the older adult population. They also observed that these effects resolved after 15 minutes post-fatigue protocol. Medemli et al. Identified no difference between young and older adult groups in terms of step length, and that they both had statistically significant decrease in step length. This study also found that the younger adult population was better at increasing their base of support post-fatigue that allowed for a greater margin of stability. Additionally, both populations increased knee flexion in response to the release in order to lower their center of mass. This may be a useful adaptation to decreased step length post-fatigue. A decreased ability to adapt with anticipatory postural adjustments was observed in a study performed by Metzauer et al. Fatigue was induced through isometric knee extension and flexion until the subject could produce 30% of their baseline MVIC. After the fatigue protocol, subjects performed a single leg reaching task. An increase in center of pressure excursion and center of gravity acceleration was observed, but with no change in the timing of EMG data before the reaching task. This suggests that in a fatigued state, Some people may continue to rely on well-established central pattern generators instead of changing them when they react to their increased postural sway after a challenge to their balance. These graphs show the change in center of gravity acceleration and center of pressure excursion, where the group of bars on the left are with the participant's dominant leg and the bars on the right is the non-dominant leg. In summary, the current literature that has been reviewed in this project of how fatigue affects balance suggests some individual variability and strategies to achieve stability. So where do we go from here? Some of you may have noticed that statistically significant was mentioned numerous times throughout this presentation. Studies chosen for this review provided clear pre-test, post-test fatigue protocols to provide an accurate and consistent representation of fatigue. While this provides great experimental use in determining relationships, it limits the ability to apply what has been observed in these studies for physical therapy and clinical use. The main limitations for this are the use of measurements such as MVIC or EMG data to determine level of fatigue. These measurements are generally not available in PT clinics, nor are they practical. After a quick EBSCOhost search, one article by White et al. Utilized the Borg scale to determine when to stop an intermittent exercise protocol and assess its effect on dynamic stability control. Future research should aim to utilize clinically useful measures of fatigue, such as the Borg scale, where changes to balance can then be observed.
All right, thank you very much. Let's give this group a round of applause. Great, and what questions do we have for these student researchers? I have one here. What were the age ranges and health for those in the reviewed studies?
Can't hear you, Blake.
Well, sorry, still not able to hear you. You're going to have to phone a friend here.
For most of the studies that we reviewed, it was actually a younger, healthy population. And so we would have liked to see or seen some articles that had more a population that was affected by a specific condition. But the research that's available looked at healthy individuals, and that gave us a good baseline research that we were able to review.
Thank you.
There was one of the articles that I know included a comparison between responses in older and younger adults. And there were some, not as significant differences as you would like to find, but there were some differences, especially in their stepping reactions. I think in the magnitude of their stepping reactions, I think was the biggest difference.
Thank you. Other questions for this group? All right, with that, we'll move on to the next project entitled Feasibility and Psychometric Properties of Performance Measures in the Telehealth Environment, presented by Stephanie Smith, Ali Steinhoff, Clay Gardner, Holly Hom, Kelly McNamara, Maria Adriana Rojas, and Nicholas Ussery, sponsored by Drs. Laurie Schroet and Tammy Simmons.
All right, hello everyone. My name is Stephanie Smith, and today my group will be presenting our project looking at the feasibility and psychometric properties of performance measures in the telehealth environment. To give a little background on why fall risk is an important metric to measure clinically, falls are the leading cause of injury-related death in the older adult population. Additionally, falls are associated with the loss of confidence in one's own balance and mobility, a loss of independence with daily activities, and an overall functional decline. Improving balance and mobility supports aging in place, which refers to older adults staying healthy and active at home, retaining their independence, and experiencing a better prognosis overall for health and wellness. Assessing fall risk in people with Parkinson's disease is increasingly important because it's estimated that up to 68% of people with Parkinson's will fall each year, and when compared to a control of the same age without Parkinson's disease, the incidence of hip fracture after a fall is 4 times higher, and the cost of medical treatment after a fall is approximately 2 times higher. So moving on to some of the main risk factors for falls in these populations, there are several balance and gait impairments that impact walking ability in the general older adult population that occur naturally throughout the aging process. These risk factors are also present in people with Parkinson's disease because of the fact that most Parkinson's diagnoses occur later in life, meaning that a lot of these risk factors overlap with the more specific mobility challenges that occur with Parkinson's, which I'll get into in a little bit. Some of these risk factors include loss of muscular strength and endurance that occurs throughout the lifespan, decreased sensory integration, and reduced coordination, which all play into the reduced ability to adapt to challenging mobility tasks and unexpected obstacles. There are several risk factors for falls that are unique to Parkinson's disease, which warrant further examination in both clinical and community settings. These impairments are caused by the destruction of an area of the brain called the substantia nigra in the basal ganglia, which reduces the amount of dopamine available, leading to motor and cognitive changes. Some of these changes include bradykinesia, which refers to slowed movements, also rigidity, which refers to a stiffness or inflexibility experienced in the extremities. Lastly, one of the main contributors to mobility impairments is the Parkinsonian gait, which is characterized by festination or small shuffling steps that can impact the fluidity of gait and the ability to lift the feet completely off the ground, increasing the risk for falling on a rug or small obstacle. Also reduced turning ability due to issues with the cognitive aspect of motor planning, which decreases the ability to turn with small pivoting steps as seen in normal turning patterns. And finally, these individuals often experience a narrowing of their base of support, meaning their center of mass is altered, which also impacts balance. So moving on to why we chose to assess these balance and mobility performance measures. Physical performance tests are frequently used in community and clinical settings to assess movement abilities in older adults and persons with Parkinson's disease. These tests are used to assess outcomes of group exercise and clinical programs, and typically movements are observed in time by a trained tester who stands close by to provide instructions and ensure accurate scoring. However, the COVID-19 pandemic caused many community programs and clinical services to transition to an online delivery format, meaning the feasibility and psychometric properties for virtual administration of these tests remains unknown.
As far as the purpose of our study, we wanted to determine the feasibility and psychometric properties of existing physical performance measures when virtually administered to a population of older adults and persons with Parkinson's disease.
And for our test battery priorities, we decided that we wanted to assess strength, endurance, balance, gait, and falls risk, but we needed to determine the feasibility of doing so virtually with the target population. We wanted to use tests commonly used in the clinical setting that have good psychometric properties. Further requirements included the use of minimal equipment and the ability to be administered safely remotely, and the ability to be timed remotely.
As far as the assessments that we chose to include for piloting in a telehealth environment, on the left here, you can see a compilation of tests that we initially brainstormed to analyze in a literature review. This included various assessments for balance, mobility, strength, and endurance. And on the right are the 7 tests we chose to move forward with. How we got from the list on the left to the list on the right involved prioritizing assessments based on clinical precedents, psychometrics, and variables that may impact feasibility. For example, we initially wanted to use a 6-minute walk test because it had solid established psychometrics for endurance. However, we found that the space requirements and angle changes could be limiting when applied in a telehealth environment. So we opted to include the 2-minute step test because research supported validity of substituting these 2 tests. I also wanted to note why we included both a 5-time sit to stand and a 30-second chair rise. Both are very similar in setup and commonly used in clinical settings and have similar psychometrics. So we decided to include both in initial rounds of testing for the opportunity to be able to further tease out which may be preferable in a telehealth environment given their similarities. While we first came up with inclusion and exclusion criteria for our population of focus that included age, level of independent mobility, among others, we first piloted our telehealth assessments in stages with participants not initially following all of those criteria. For our first stage, we piloted among ourselves, the student researchers, then with graduate assistants, and then with family members, all to apply and continually refine our methods. And we are currently in the process of preparing to explore testing our methods on our focus population. Piloting remote assessments included troubleshooting various aspects of our methods to ensure feasibility during 1-hour telehealth sessions with participants. Our objectives included exploring optimal testing order during the telehealth session, keeping in mind variables such as fatigability, movement-induced dizziness, and number of camera angle changes. It also included pre-session preparation, including advising our participants ahead of time on home setup and setting expectations, all to ensure efficiency. For our testing equipment needs, we had to think outside of the box by thinking inside of the manila envelope containing the kits that we plan to be able to mail to participants. This included developing foldable pop-up paper cones and including pre-labeling tape for markers needed in our assessments. For technology, we opted to be open to any portable electronic devices with video and internet capability.
So our initial pilot testing was conducted with the help of 6 researchers and GAs, and ultimately we decided to separate the pilot testing into 2 phases. The first phase included the researchers and GAs, and the second phase included family members. Within the first phase, there were 6 trials conducted, 3 with researchers and 3 with GAs, and we had various objectives in mind. Initially, with the researchers, we wanted to determine the general feasibility of the project, and another goal of ours was to explore setup variations and improve overall testing efficacy. Our sessions with the GAs were rather informative, and we enjoyed having GAs as they were unfamiliar with the testing protocol and provided us with a fresh insight. One of our main objectives with the GAs was to find a camera angle that required the least number of adjustments necessary for successful completion of the test. Lastly, we wanted to get an idea of how much time would be required to perform the battery of tests virtually and think of ways to potentially reduce this time commitment.
So now I'd like to transition into the lessons learned with our initial pilot testing with researchers and GAs. So during the trial period, we recognized that there are a variety of tripping hazards that can present themselves within the home environment. With this realization at the forefront, we wanted to make sure that we didn't introduce too many additional confounders that our participants could trip over. And we realized that the equipment we utilized in the pilot testing needed to be easily visible over telehealth and easily applicable to surfaces that already exist within the home environment. So with this process, we decreased the amount of tests to reduce redundancy and obtain functional measures that are easily observable through telehealth. We initially began with a selection of 13 tests through our review of the literature. And after obtaining guidance from our instructors, we selected 7 must-have tests that would allow us to assess a participant's functional capabilities in measures such as gait speed, balance, endurance, and strength. The order of testing was selected to minimize position changes of the participant, as well as minimizing changing camera views during that setup. This order also allows for optimization of periods of rest that prevent the participant from fatiguing too quickly from the test battery, as was suggested by our GA participants. The pilot testing also allowed for examiners to standardize their scripts and processes when working with participants, as well as develop methods that can simplify the measurements obtained from the setup. Instructions such as placing the camera closer or further away and clarifying our communication were pivotal during this process due to the nature of having to perform a remote session. With the testing kit, we began with supplies that we thought would be best for implementation within the study. Over the multiple stages of trial periods, refinement of the testing kit that could be sent to participants was formulated in order to facilitate standardization of materials that were utilized for measurement. Now, I would like to transition to further presentation of our pilot testing.
We did the next pilot study with family members because we wanted to practice with people closer in age to the target population who were unfamiliar with the tests and had varying levels of technological skills. We knew the pilot testing would be safe and feasible because we're familiar with our family members' physical abilities and home setup. We also asked them to participate because we knew that they would be willing to spend time to help us learn and that they would be willing to give us honest, constructive feedback.
And during this phase of our pilot testing, we gained a lot of valuable information about mailing a testing kit to our participants, including the time frame needed for delivery, the feasibility of conducting our battery of tests with various electronic devices, leading to the development of strategies for adapting our protocol for the use of laptop computers, tablets, and cell phones. We learned that we need to further reduce the required camera angle changes, became more efficient at evaluating their home environments of the participants, looking for changes in flooring surfaces and other safety concerns. We learned our language needed to be further simplified to include clear, concise, loud communication free of any technical jargon. And we, at this stage, began improving the consistency of scoring between our student researchers. And moving forward, in our next phase of testing, we will incorporate mailing our test kits to all of our participants. We will administer a battery of tests in the same order, if possible, with each participant. We will establish clear vocabulary to use when guiding our participants through their home setup, designate roles for the student researchers, standardize scoring procedures, and begin recording each session so that we may further improve scoring consistency between the student researchers. We hope to collect data and then calculate inter and intra rater reliability. Oh dear. And so at this time, we are also, I believe there's a tornado warning in our area. Parts of that slide did not, let's see. You're missing a picture. I'm so sorry, everyone. Please forgive me. So here, I wanted to talk about some considerations that we would like to acknowledge, including the modifications that we made to protocols to allow for feasibility of remote administration that may impact validity and psychometric properties of these tests, or of our battery of tests. So one example is that for the 2-minute step test protocol, we decided to accept a measure of the participant's arm resting at their side and using where their arm reached their mid-thigh, rather than attempting to, Dr. Eckert is expressing concern. I think it's just the county. I'm sorry. So we chose to accept their arm resting at their side at the mid-thigh as the required height for each step to count as a valid repetition, rather than attempting to instruct participants to palpate appropriate bony landmarks and then measure a halfway point as the original test protocol requires. Ideally, you would be seeing a picture of that right now. Another example is that for the timed up and go, we chose to allow the use of a sturdy chair without armrests in place of a sturdy chair with arms, as the original test protocol requires. We thought that by prioritizing these small changes that we could include more participants of our desired population. We want to address that there were a few other appropriate measures that we were unable to utilize because we had to prioritize those with scoring that is forgiving with timing to prevent complications from lag time due to internet connectivity. And finally, we may have limited the generalizability of our study by selecting participants that are not necessarily representative of the population because we were unable to use those that were at greatest risk of falls to account for safety.
So what's next? First and foremost, we'll be obtaining IRB approval so that we can recruit and test adults and persons with Parkinson's disease that fit our target age range of 50 years and older. Next, we'll conduct our analysis in order to compare to existing normative values and determine inter and intra-rater reliability. This will have us well on our way to achieving our goal of revolutionizing performance measures in a telehealth environment. There's also an opportunity for some future research, potentially post-pandemic, to look at the changes in psychometric properties when our same test battery is performed with the same participants in person. And at this time, we'd like to thank our wonderful faculty advisors, Dr. Schroet and Dr. Simmons, for their guidance in designing this project, as well as our family members and the first-year graduate assistants for helping us collect pilot information. Thank you so much for your time.
All right, thank you. Let's have a round of applause for these student researchers. I would just remind everyone that this event is being recorded and will be shared via email on the graduate school website. So if at any point you need to log off and shelter in place, you do what you need to do. That's, of course, our primary area of importance to us is your health and safety. But with that, for those folks that are able to stay here, what questions do we have for this research team? I have a question coming in here. Would any of these telehealth tests be applicable for patients who use assistive devices to ambulate?
So our main concern, because I know that sometimes with these measures, they will specify using an assisted device or not. Our main concern right now is that they do not require the use of a researcher to guard them for safety. So if they would potentially fall while completing these the measures, I don't know that we feel safe including them just now.
Thank you. Our next question is referencing the slide with the cone on it. Is there a patent on that particular design? A future
That was a joke.
No.
It was a joke, but I think that there should be. And Maria Adriana designed it, and if anyone takes it, we will know it was you.
This is being recorded, so keep that in mind, everyone. Other questions for this research group? All right, very good. And that will bring us up to our last group of the session today, a project entitled Clinical Benefits of Blood Flow Restriction Training in Patients with Musculoskeletal Impairments, presented by Mark Steele, Kyle Baraski, and Dylan Wells, sponsored by Drs. David Hudson and Josh Jones.
Thank you, Dr. Eckerd. Holy cow, those are some great presentations. I definitely like to tip my cap to everybody, all the hard work. Those are a lot of tough acts to follow. I feel like we're following up the murderer's row of the 1920s New York Yankees. And if just one of you guys got that reference, that'll make it all worth it. Nonetheless, my name's Kyle Baraski. Together with Mark Steele and Dylan Wells, we developed this doctoral project under the guidance of Dr. Dave Hudson and Dr. Josh Jones. After scouring the literature for all things BFR, we developed this tutorial video with the intent of it being a starting point for clinicians who are hoping to utilize BFR in the clinical setting. And without further ado, Mark, please take us away.
Cool. Can I get some thumbs up? People can hear me. Excellent. All right. Let us begin. Y'all can all see my screen, I'm hoping. Excellent. All right.
BFR was created in the mid-1960s and was originally called Katsu training. It gained popularity in the fitness industry quickly and has been utilized informally as a method for promoting strength and hypertrophy gains. It has only relatively recently gained popularity as a clinical tool in recent years, as the body of literature surrounding the topic has matured and demonstrated its safety and efficacy for use in clinical populations.
For physiological concepts, the overarching intent of the application of blood flow restriction is to allow partial arterial blood supply to enter the occluded limb while restricting the venous return of blood out of the limb. This creates a pulling effect in the limb that theoretically extends the metabolite signaling in the target extremity. There are other factors at play in this process, such as the increased cellular swelling effect. However, the purpose of this video is to not describe these processes at length, but rather to outline the clinical utility and practical application of BFR in the clinical setting.
One of the major limiting factors of rehabilitating many musculoskeletal injuries is the difficulty of meeting the ACSM guidelines for strength and hypertrophy training, which dictate the need to utilize 70% or greater of the 1 repetition maximum for a given movement. Blood flow restriction exercise allows us to attain gains comparable to traditional strength and hypertrophy training without the need to apply these elevated loads to compromised or sensitized tissues. This has obvious clinical utility as it allows us to prevent disuse and atrophy while also maintaining and even improving strength and hypertrophy during time that would otherwise be limited to relative rest and low load exercise with significantly limited productivity, which can have its own negative impacts on function and well-being.
For safety considerations, the main contraindication is known DVT or high DVT risk. Other safety considerations are signs and symptoms of syncope, impaired sensation, elevated blood pressure, muscle soreness and damage, severe discomfort, and performance breakdown.
Many occlusion parameters have been investigated with a range anywhere between 40 and 80% of the limb occlusion pressure proving effective. Occlusion parameters may need to vary depending on patient comfort, but evidence does support the use of higher pressures if tolerated. There are also evidence-based effective load ranges between 20 and 40% of the patient's 1 repetition maximum. We recommend the use of calculated 1 repetition maximum with some clinical populations, as true 1 repetition maximum testing could have deleterious effects and place the patient at risk of further injury. The use of sound clinical judgment and careful consideration of the individual is vital for the application of BFR. Here we have a chart from an article by Patterson et al. That further outlines common parameters seen in the literature for application of BFR.
To begin, the clinician will ask the patient to roll his shorts up to the inguinal crease so that he can slip a moisture-wicking sleeve up over the leg and high under the thigh, ensuring there are no wrinkles in the sleeve that could become uncomfortable for the patient later on during exercise while the cuff is inflated. The clinician will then ensure that the cuff is facing the correct direction, which may differ depending on the brand of cuff you are using. The instructions for these cuffs state that the valve should be pointing towards the patient's head. The clinician will then tighten the cuff around the patient's leg by pulling on the straps. If the cuff is too loose, it may not achieve its goal of occluding venous blood flow, but if it is too tight, it may begin occluding blood before the system and the patient are ready. The clinician should use the 2-finger test, making sure that there is no more than 2 fingers width of space beneath the top and the bottom aspects of the cuff. Once the cuff has been fitted properly, the clinician will finally attach the hosing to the valve and prepare to set the occlusion parameters on the unit. The next step after fitting the cuff over the patient's target extremity is to turn on the machine and allow it to calibrate. Once completed, the home screen will show up where the clinician selects the icon in the top left corner to bring up the main menu. From here, the clinician can select any of the preset parameters on the upper extremity page, or, for this patient, the lower extremity page. Additionally, there are customizable upper and lower body settings, but the desired limb occlusion pressure for this patient was already programmed into the preset settings. Once the occlusion pressure has been selected, the clinician will press the calibration button and the machine will take a few moments to determine the pressure needed to occlude the limb's blood flow by the pre-selected percentage. For this patient, the clinician has selected a limb occlusion pressure of 80%. This is consistent with much of the available literature, which states that 100% venous occlusion and 80% arterial occlusion yields the most successful results for strengthening the lower extremities. Once this process is complete, the unit will display the calculated pressure for the clinician to approve or recalculate. From here, the machine is calibrated and pressing the start button will inflate the cuff and the patient can begin exercising. Doing so will also start the timer on this unit.
Here we will be demonstrating a few common lower extremity exercises that are effective for functional strengthening. The application of BFR to the lower extremity can be useful for a variety of clinical presentations that affect normal loading capacity. There are essentially endless ways to utilize BFR training and similarly numerous deficits that would benefit from its application. Studies have indicated that high volume sets with a focus on the concentric portion of the lift are the most effective for producing strength and hypertrophy gains similar to that of traditional resistance training. A very widely utilized set and repetition scheme that has been shown to be effective repeatedly in the literature is a set of 30 followed by 3 sets of 15 with 30 seconds of rest between each set. It is not uncommon for the patient to fatigue before finishing all 15 repetitions of the last 1 or 2 sets. This should not be a major concern, and it is thought that the volitional failure may be beneficial for muscle growth signaling.
The built-in timer on this unit will continue to run until the patient has completed the desired number of repetitions and the clinician presses the pause button to allow the patient a 30-second rest break. The unit will then beep when it is time for him to resume exercise. In the event that the clinician wants to deflate the cuff before time has expired, he can pause the unit and press the deflate button.
The application of the cuff to the upper extremity is the same as the application of the cuff to the lower extremity. Again, ensure that the valve is facing the correct direction. In this instance, the valve is facing towards the patient's head. Note here that the cuff size is smaller, corresponding to the smaller size of the upper extremity compared to the lower extremity. The cuff is placed in the proximal upper extremity. Once more, the clinician uses 2 fingers to ensure that the cuff fits appropriately. In this video, the patient is demonstrating a variety of upper extremity exercises. As with any exercise, the clinician should be diligent, observing for proper form and any signs of adverse reactions to the exercise. The upper extremity protocol is similar to the lower extremity protocol. The patient will complete 4 sets, the first set of 30 reps and the subsequent 3 sets of 15 reps each with 30 seconds of rest in between each set. The main difference here is that the limb occlusion pressure will be set to 50%. The reason for this is that the arm is a smaller limb compared to the leg, and anecdotally, high pressures often produce excessive discomfort and preclude the patient from continuing with exercise. The evidence supports that 50% limb occlusion pressure in the upper extremity is effective for muscle strength and muscle mass gains. Once again, the load should be between 20 and 40% of their 1 rep maximum. It is important to note that the North Carolina Board of Physical Therapy Examiners determined in December of 2019 that blood flow restriction training is within the scope of physical therapy practice. However, it is incumbent upon the licensee to obtain the appropriate training and education to be competent to perform this technique in a manner that is considered safe and effective for the patient.
We hope you found this video helpful. As always, sound clinical reasoning and judgment should guide the use of any prescribed intervention in order to maximize safety and efficacy for the individual. Thank you for watching.
All right, let's give this group of student researchers a round of applause. And let's see, we have our first question already here. An audience member wants to know, do clinicians usually use this unilaterally, or can it also be used bilaterally?
So it just kind of depends on what the target tissue is. Like we stated earlier, it did gain popularity in like a kind of a recreational workout setting. That's kind of initially where it started, and then progressed into kind of a clinical setting. So if you've ever been at the gym and seen someone with like straps around their arms or legs or whatever, a lot of people will use it bilaterally. absolutely can be used bilaterally. But in a clinical setting, unless you're rehabbing, two arms for some reason, two legs, whatever, I think generally you would see it just unilaterally.
Thank you. Our next question from the audience notes that BFR is generally pretty uncomfortable. Do you guys know how many clinical populations might be interested in buying into that sort of treatment?
Yeah, so that's a good question. The current standard for that is you basically start at the lower end of the effective range that's been identified in the literature, and then from there you kind of titrate up the occlusion pressure percentages. So you may start at 50% if they can tolerate that, and then work towards the 80% as they develop tolerance.
Thank you. Another audience member wants to know, are there very strict contraindications for using BFR?
Yeah, so basically DVT is one of the big ones. If somebody has a risk for clotting as a pre-existing condition, that's also a contraindication. There's a variety of precautions, such as you wouldn't want to put it over the like an incision site or a wound, or if they have impaired sensation, something like that. Contraindications are actually pretty few and far between. It seems to be relatively safety for most clinical populations.
Thank you. As a follow-up to the question that I think you responded to, Dylan, about clinical populations, the audience member wants to know, can they still get a good benefit from just 50%?
Yeah, so definitely. It's kind of getting back to like, if you can tolerate it, it's going to be significantly better than simply light load training. And that's been demonstrated numerous times in the literature. So basically, if you can tolerate that, you're going to be better off than simply light load training. But as you can progress, you may see more and more gains to a certain extent, though.
Absolutely, Dr.
Kind of follow up with what Dylan was saying. A lot of things that are being reported are you kind of want to match the limb occlusion pressure with the percentage of their one rep maximum that they can complete. So if they're like at the lower end of their 1 rep maximum, you'd want to have a higher limb occlusion pressure to try and elicit as much gains as possible. But if they're upper end of that spectrum, then it's like more advisable that you can move the limb occlusion pressure down a little bit. But ideally, you're in that 50% in the upper extremity and 80% in the lower extremity. And then also kind of going off your question about older adults, this is very promising for patients with sarcopenia, because if you're in that state, you're not going to be able to be lifting at 70 to 80% of your 1 rep maximum. And that's where BFRs really believe that it can come into play for those individuals.
I also wanted to follow up with that.
20 or 30% of their 1 rep maximum and still get comparable gains. But it's important to note that outside of that population, there are studies that show that the gains with BFR are comparable to lifting at high intensity. But in most studies, if you're able to lift at that point, you should lift at that point. So this is really ideal for those clinical populations after surgery, after an injury or sarcopenia, where they're just unable to generate that kind of tension in their tendons and muscle to elicit these gains.
And another point to follow up with that is that BFR is actually, several studies have shown that it can have a analgesic effect as well. So sometimes when people are in pain or are limited by, say, pain from osteoarthritis, something like that, this can be a great way to enable loading of tissues that otherwise would be limited by pain. So it can be a great pain management tool with the continuation of loading.
Thank you. Another audience member noted that it looked like a leg turned pretty blue in that video. Would you have stopped using it, or when might you stop using it during activity?
So as with a lot of interventions, well, I guess a lot of exercise interventions, you will sort of allow like extreme discomfort to guide that. So, I mean, I can't speak to lower extremity because I didn't try the lower extremity, but for the upper extremity, certainly got tight, became uncomfortable. but never, it never felt as though like my arm never felt like it was going numb. It never got uncomfortable to a point where I felt like I needed to stop, deflate, anything like that. But certainly, I mean, they have that deflate button. But at least the unit that we had that deflate button readily available. So at any point, if it became just too unbearable, that is an option.
Thank you. And
also, the unit we were using is considered the gold standard because at that point it's considered a tourniquet, and for us in our profession, that's defensible if anything were to happen. But if you're using like the bands or these lower quality cuffs that you might see some people using at the gyms, those aren't classified as tourniquets. So if you're considering that for your clinical practice, you should try and go with the gold standard. I think Dr. Hudson noted in the chat that they are about 5K. But the research is definitely pointing in that direction. That's the way to go.
And another thing is that this is the Delphi system is the only FDA approved unit at the moment. So some clinicians are considering that as maybe a factor for choosing a unit for their clinic because that's the most defensible theoretically.
Additionally, Delphi does. So they are part of, I believe they are part of the Owens Recovery Science team. They're the ones that put that unit out. I believe I'm not mistaken with that. But they do, before you're allowed to actually purchase one of those units, you do have to have proof that you are some sort of like medical practitioner of like, you have to have, they have a cutoff in terms of like, you have to have a certain degree in order to even be able to purchase one. And then they have a training course that we obviously did not purchase because we only borrowed the machine. But they do have, they require you to go through some level of training before you're allowed to buy one of those machines.
Great, thank you. And our last question for the audience asks when this video will be available on YouTube.
So, summer of 2021. I'm just kidding. We have no plans for that at this time, but we will follow back up on that question at a later time.
Absolutely.
Actually, I will say that this kind of circles right back to our first presentation because we plan on kind of including a treatment side of that video-based learning tool. And this would be one of the first instances of kind of including some type of a form of treatment, and the other side of the house would be the assessment that the first group did.
Great, thank you. And let's go ahead and provide this group another round of applause. And let's add in a round of applause for all the groups today. All the groups today, excellent. Dr. Hudson's going wild, excellent, excellent. All right, well, we will have our formal closing in just one moment, but I did want to note two things prior to that. The first is, wow, just an awesome job done by everyone and every group. You all should be proud of you. I know I speak for every member of the faculty when I say I am proud of you. Because the breadth of information covered and the range of topics we had, the depth at which you were able to cover them in a relatively short amount of time, and the amount of creativity that you displayed in getting around the COVID pandemic, just absolutely outstanding. Extremely well done, everyone. The second thing I'd like to note is that presenters and faculty members are requested to stay after the formal closing here for some photo ops or virtual photo ops as it may be, so that we can remember the event today. But with that, we'll have our formal closing. We would like to thank the Western Carolina University Graduate School and its Dean, Brian Kloppel, for their sponsorship of the event today, along with Dean Joy Bowers-Campbell and Ms. Jan Stanfield for their help in facilitating this event. I'd also like to thank all the faculty mentors involved in these projects and my fellow three moderators who are working hard behind the scenes to help put on the session today. AC Cruz, Jenny Flowers, and Maddie Reckenberg, if you would give them a round of applause with me here. Thanks, guys, for all your help. You helped make this happen. I would just like to remind everyone that I will provide a link via email to everyone in the department tomorrow to be able to view this, and you will also be able to view this video on the graduate school's website. With that, we will have the end of our formal closing and the end of our festivities today. Thank you and have a wonderful evening.